treatments that a person can sign up for. Ooh, think about that one. And so they can deal with perhaps anxiety. Now, I would say that's something you really shouldn't do, but that should be supervised at least by a psychologist. And then maybe the psychologist can also make a secondary referral to a psychiatrist or primary care doc. So what I'm saying is the bottom line is pharmacists are now becoming, depending on where you now work, are looking at being first-line screening agents for anxiety as well as even for depression. Okay? All right, so let's drill down with benzodiazepines, okay? Keeping in mind, benzodiazepines, when they first were developed, and they continue to be, really are the most effective, and I say safe, relatively safe, compared to overdose situations, to antidepressants, for the rapid relief of anxiety, So, for example, if you have a person who is really anxious, has muscle aches and pains, that are stiff, that sort of thing, a benzodiazepine is very reasonable to give to them. When we say rapid, it works what? Literally the first couple of doses, because they'll start feeling a little sedated, muscles will get relaxed. That is something that is rapid. As we previously mentioned when we talk about the antidepressants could take longer, weeks. So you have to think about therapeutics and why the drugs are combined, okay? The kinetics are presented to you, and we'll go over them, but they vary in their kinetic profile, and we'll point out some things to that. Buspirone is an optional treatment. Now, the caveat with buspirone is that it's only good for patients without comorbid depression. So it has to be used by itself. And that's very difficult to do, especially when you have so many patients that have both depression and anxiety. So finding a pure person with just generalized anxiety disorder is really hard to find. Okay, and we'll talk about the treatment algorithm in your textbook, and then a couple words about alternative treatment. Hydroxyzine is an old-time antihistamine drug. Has been used in the past, but it's a very potent antihistamine that just causes sedation and a lot of anticholinergic side effect. It's not really addressed any core anxiety. Kava is not shown to be effective, but it's one of those alternative complementary things, and they have demonstrated possible hepatotoxicity. So it's really not preferred. Pregabalin is off-label. It's in your textbook as well. Pfizer just got fined about $400 million for off-label use of anxiety disorders and pregabalin. So Pfizer didn't mind because they made $3 billion from it. So it's one of those things. Okay, so this is in your textbook. First in its therapeutic algorithm. You can see here, first-line drugs, they take it in 3 categories. That's what we've done here. Generalized anxiety disorders, panic, and social anxiety disorders. First-line agents are here, your second-line agents are here, and then alternatives. So you can see here your first-line agents are really your antidepressants for generalized anxiety disorders. We'll go on to panic and social anxiety disorders in subsequent slides, but we're going to right now just stick with the generalized anxiety disorders. You see here, they're second-line drugs. You see, this is where you see pregabalin again. Your textbook puts that in there. Most people do not use it, okay? So you can just line that one out. I won't ask any exam questions on pregabalin for anxiety disorders. I may ask them for other things, like epilepsy. Remember epilepsy? The final exam will have epilepsy, by the way, and all the other topics. All right, so you can see here, second-line agents. You see now the benzodiazepines and buspirone, the 2 drugs and drug class and drugs that we'll talk about. You see good old imipramine. Boy, that still rears its ugly head. Some of these old tricyclics, you'll see them in therapeutic algorithms for various PBMs and other formularies because it is pennies on the dollar. It is about the cheapest generic tricyclic you can get. Okay, and there's actually clinical data from the early 70s that show that it works. So, okay, that drug will probably never go away. Hopefully no one really uses a whole lot of imipramine for anxiety disorders because, A, got all those tricyclic side effects, but also you could see that you really have better choices of first-line agents. And then alternatively, you see there hydroxyzine. I already mentioned that. And then the last one you see is quetiapine. Quetiapine, that atypical antipsychotic, as you can see that people have tried to use it, continue to try to use it for a lot of different reasons. Low-dose quetiapine, like less than 150 milligrams in an adult, not a person with BPSD, okay, in an adult. The antipsychotic dose for quetiapine, you got to hit about 300 milligrams. So the question becomes, what if you use it for lower things? People have tried it. They actually did clinical trials with quetiapine at 50 to 100 milligrams for generalized anxiety disorders. It showed that it may work, but didn't separate too much from placebo, so the FDA did not approve the indication. But that doesn't mean it's not used offline or off-label, and your textbook puts it in there. I'm not real thrilled about it, but you know, it's one of those things that's there, and you may or may not see it. Okay? Okay, so now let's look for the benzodiazepines as we look as a second-line agent for generalized anxiety disorder. So here's the your table in your textbook with the different agents. You see the approved doses here and their max dose comparatively to geriatric patients. That's this column here. Okay? And then the approximate equivalent doses. So basically they put that table in there to see when some clinicians may want to interchange benzodiazepines. So like switch from one to another. I don't recommend that. Most people just stick to the one benzodiazepine. If you are going to switch, you try to switch within the kinetic class, meaning that if you have a long-acting one, you switch to another long-acting one. You don't switch long-acting to short-acting and vice versa. Okay? And you can look at the short-acting just when we look at elimination half-life, which we'll show you shortly. Now, you see the upper dosage ranges that are approved. Very rarely, it depends on certain situations, but at least for generalized anxiety disorders, these are pretty much the max doses. That doesn't mean a person can't use more. You may see prescriptions for, like for example, diazepam 60 milligrams a day, and you wonder how could they even function with that because of all the other problems that we'll talk about with benzodiazepines. Today we look at benzodiazepines like we do with antipsychotic drugs. People tend to stay at the lower doses, okay? That's a lower dose end range. Now you see here at this one, just to point out, these two benzodiazepines are preferred in the elderly. The reason for that is that when you have a person with diazepam with a long half-life, it extends the half-life in geriatric patients. And if you have benzodiazepines and geriatrics, they did long-term epidemiological studies that long-term benzodiazepines have a higher risk, like by 3 to 4-fold, of causing falls and hip fractures. So that doesn't mean they're still not used. You still see them out there, but that's what the data shows. So these that don't undergo a lot of, due to their kinetic parameters, are preferred in the elderly. And so here we have, again, the non-benzodiazepines. You've seen this before. It's in your textbook. It's the antidepressants. The same rules for dosing SSRIs, SNRIs apply. So there's nothing different with that, okay? And at the same time, you could see which agents have actually FDA approvals for generalized anxiety disorders, okay? And then, of course, you see some that are noted that have generics, okay? So this is your therapeutic algorithm. It looks really complicated just for generalized anxiety disorders. Who had thought anxiety would be so complicated to treat, right? Gee, but like any other algorithm, you know, if we take it in bits, it's little more rational and easier to digest. First of all, you've got to evaluate the patient. You look at each stage, make sure that there's no comorbidities. Well, if there are, like depression, then and they need medications, that certainly will lean toward your antidepressants. Have to rule out any type of suicidal ideation, insomnia, all those other comorbid things. That's the first thing. Second thing, let's go down this way. It says medication, all right? Which ones to use? SSRIs, SNRIs. Great. Remember, they're first-line agents. They work pretty darn well for treatment. And then if it doesn't work, if an SSRI doesn't work, then you switch to an SNRI. Simple. Okay? Now, if you do have the need for benzodiazepines, this is where you get into the other layers. Okay? So, for example, if the person needs rapid relief, that's when benzodiazepines would come into the picture. Okay? And then, of course, when you have combination therapy, you begin to monitor, and then all these other caveats start to come up when you have comorbid symptoms. So really, right now, I'm asking you is really looking at SSRIs, SNRIs, then we'll look at buspirone, and then we'll look at benzodiazepines. Usually, we don't get into the refractory stuff because that'll be really more for individual primary care physicians. But we're just going to present to you the evidence for really first-line and second-line agents. Okay? So, atypical antipsychotics, as I mentioned, have been used. This is the one study that looked at quetiapine, and it was found to be equivalent to 20 milligrams of paroxetine a day. Okay, seems to work. Would like to mention, pregabalin not approved in the U.S., but approved in Europe, so okay. All right, so now, generalized anxiety disorders. To mention, we'll show you some tables. I was just going to say that you could see these are some of the agents that are FDA approved. So yeah, you could use all of them, but keeping in mind their side effect profile. That still didn't change, okay? It's been shown to be effective for that psychic symptom associated with generalized anxiety disorders, that constant worrying. Isn't that interesting? And I mentioned, although imipramine is used, few people use it. Response is delayed 2 to 4 weeks, but could take longer, and we'll show you that. Okay? So think about its particular caveats. And again, all the side effects, all the drug-drug interactions, you've got to review your depression chapter. I say, please review. So that's all I'm going to say about those antidepressants. So then I'll now focus in on benzodiazepines. As mentioned, it is the most effective agent for acute anxiety. Acute. Person needs relief like today. That kind of thing, okay? Now, there are a lot of benzodiazepines. We've shown you the list. There are more of them. Dr. Emmett showed you a bunch for insomnia. We're going to talk about that on Friday. That doesn't mean you can't use either one. So, for example, if lorazepam is approved for generalized anxiety disorders, you could use it for insomnia. It's just not FDA approved. Okay? And vice versa. If you have a benzodiazepine that you want to take for insomnia, you could use that for generalized anxiety disorder. It's just not FDA approved. Okay? So a benzo is a benzo is a benzo. All right, first thing. Keeping in mind that alprazolam is approved for panic disorder with or without agoraphobia. But alprazolam occupies a special place. When I talk about the dosing, and we look at that, when we see the dosing table for alprazolam, it differs for panic disorders. Some folks, and it is FDA approved, for up to 10 to 12 milligrams a day. Think about that one. That's high-dose alprazolam. That person has to be pretty darn ill